All right, everybody. So I'm going to be talking about chest tube complications for my procedure today. It will be a little bit interactive, so I'll just be pointing out into the crowd. So don't be surprised if I just point at you, Dr. Lucchese. So let's see.
Try next slide. Or yeah, you got it.
Right. So this is what we're not going to be talking about. We're not going to be talking about logistics of like how to do a chest tube. It's not going to be the step-by-step of like this is what happens next. What we will be talking about are the complications of proper placement, complications of improper placement, and how do we mitigate some of those risks for improper and proper placement complications. So just a 20-second overview of how to do a tube thoracostomy. First, you poke, then you bluntly dissect, watch out for blood. You want to do some finger sweeps, right? Bam, 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 bam. You want to clear away those adhesions. Then you want to hook it up to suction, suture it in. So, complications. There we go. All right, so first up, Dr. Lucchese, is this properly placed or improperly placed?
Improperly.
Correct. It's a kink chest tube. So the way that we fix it is we just pull it out a few centimeters. Next up. All right, so Dr. G.
Okay.
Properly placed or improperly placed?
Can't tell.
All right, great. So here's the little animation. So you have this is an intraparenchymal placement. So you've essentially stabbed the tissue of the lung. In this case, there's a little bit of hemorrhage associated with it. And part of this shows that you can't always tell with the chest X-ray. If you think there might be a complication, you do have to go ahead and get a CT if you're suspicious. So what do we do in that case? Well, if they're dying, you go back to your ABCs and you prepare some blood, prepare for a bedside thoracotomy. And if they're doing fine, you can just kind of withdraw a little bit, help with the actual pneumothorax because all the holes might be in the substance of the lung. Eventually, you'll have to replace it, but you might be able to temporize it. But if they look good. So next up, I'm going to go with somebody in the 7th row, whatever. Somebody.
Oh, me?
Anybody. Properly placed or improperly placed? All right. What do you think's going on?
I think it's the possibly you don't even see it.
I'm sorry?
I don't even, it's possibly in some queue, I don't even see it.
All right, cool. So this is an extrathoracic lung placement of the chest tube. If it's malfunctioning, you kind of have to suspect it. And this is the CT scan to confirm that it's not in the substance of the thorough. You can see that the pneumothorax is not resolved. And then you also have to watch out for a little extra bleeding depending on what you might have lacerated. So in this case, pull it out. So somebody else.
Improperly placed.
Improperly placed. All right. It's a 50-50 shot, right? So in this case, it is next to the right atrium. And so in these cases, as long as there's nothing going on, you can pull it out a few centimeters. The reason you'd want to reposition it is because with variations in movement or breathing, you can actually push it into the substance of the heart. The other thing you have to worry about is the fact that you might be pushing on a coronary artery. You might be causing a contusion of the heart. So in these cases, you want to pull it out a little bit and monitor them. There have been some instances of irritating the pericardium, causing atrial fibrillation or other sorts of dysrhythmias. So this one's a little bit of a story, all right? So you have a 21-year-old male with cystic fibrosis, and he ended up with a right-sided pneumothorax. You can see that the pneumothorax, or that the chest tube has been placed, but is it properly placed or improperly placed?
Improper.
What's up? I think I heard somebody mutter the correct answer.
Let's go with improper.
Improperly placed. But this just goes to show that sometimes you need the CT. In this case, it was placed between the parietal pleura and the chest wall. They actually had aspirated the tube, got it to work for 24 to 48 hours, and then it failed again. Then they went ahead and just replaced the chest tube, and it worked fine. So you pull it out. All right, so another story. This is a 35-year-old male with, he has 2 histories of pneumothoraces in the past. So about 30 hours ago, he developed some left-sided chest pain. The left-sided spontaneous pneumothorax was identified on a chest X-ray. The team went ahead and placed the chest tube. The lung re-expanded. But now, 50 minutes go by, and he has some new chest pain. His throat's tickling a little bit. Team goes ahead and retracts it another 5 centimeters. 40 minutes later, patient still has chest pain and throat tickling. A little bit after that, he develops cough, shortness of breath, tachypnea, tachycardia, and you go ahead, intubate, mechanically ventilate. But what happened here? Is it properly placed or improperly placed? Bueller. 50-50 shot. This is properly placed because this is re-expansion pulmonary edema. Risk factors for re-expansion pulmonary edema are young age, large pneumothoraces, if it's been going on for more than a day. Some places said maybe 24 to 48 hours, and rapid re-expansion. So how do we prevent it? Well, we just kind of identified some risk factors. Young people with large pneumothorax, that's been going on for a while. If you suspect that they might be at risk, what you can do is you can place them to water seal, and if it's still not re-expanding, you can place it in on suction, but less than 20 centimeters of water. And if you know that it's going to be more than a liter of either fluid or air, then you can intermittently clamp the tube. And while you're treating them, you put them on the disease side up. Blood is gravity dependent, so you want the blood to go to the healthy lung. And then if you need it, you can place them on CPAP or bypass, kind of treat it like an ARDS patient. In this particular patient, after intubation, he's placed on CPAP, extubated about a day later. So, all right, both wrong. There's 2 of them. It's a little more than a 50-50 shot because I'm asking you for two answers. Dr. Willis.
Re-expand. Maybe the left one is too far in.
So these are both, this was my excuse to throw an outcast into the PowerPoint presentation. So they are both all right. These are both properly placed. So, another story. This is a 30-year-old male. He had bilateral rib fractures. He was treated with bilateral chest tubes. And so, what do we think here? Look good, look bad.
Lungs are re-expanded.
Yeah. So lungs are expanded. I think I heard it. Yeah. Want me to give the answer? All right, so you ended up with Horner syndrome, right? And so if you go ahead and you look at the left apices, it is placed a little bit too superiorly. So it's kind of a right and a wrong answer because at one, you're trying to fix his pneumothorax. His pneumothorax is fixed. Then you go and you find out that he has meiosis and maybe like a droopy eyelid. In this case, it ends up being a little bit more complicated because you see that in the context of this like terrible trauma, then you have to go and investigate central causes of Horner syndrome. When in reality, it was iatrogenic. And so this individual ended up with a pretty extensive workup just to investigate what was causing his Horner syndrome. And the way that they ended up treating it was they withdrew a little bit, and then within 6 weeks, everything resolved. And so just to superimpose, I pointed out where the third rib is, just for reference, but then also I grabbed my netters. And then all I need to do is pull it out a little bit. And so how do we avoid these complications? Well, you have x-ray ready at the bedside if you want to manipulate it quickly. You can make sure that you stay in your triangle of safety. Make sure that you sweep and guide, right? Wipe away those adhesions, prevent going into the intraparenchymal space, and you can redirect it inferiorly if you think that's where there's blood, or superior and posterior if you're trying to get rid of pneumothorax. You can always use an ultrasound to determine where you want to go and make sure that it's a safe place for you to go. You can always get your surgeons early in case there are complications of the chest. So this just goes over what we talked about. Complications of proper placement include re-expansion pulmonary edema. Complications of improper placement, essentially you're stabbing them in a place that should not be stabbed, or placing it next to the heart, placing too superiorly and causing Horner syndrome, or just kink tubes in general. How do we mitigate those risks? Essentially be prepared, know where you're going to be placing the tube, and you can use the bedside ultrasound. So Any other questions?
Did you say anything about the amount that you should be putting the tube in based on like measuring the patient, like that?
I didn't, but I think classically what I've been taught is that you kind of measure the curvature from the clavicle to where you'd like to place the tube, and that's kind of like a good way to measure your tube prior to placing it.
I think it's a good thing to do if you care to do it because it gives you an idea of where you should be going, and if you're past that or not far enough to be predicted. And then obviously you want to make sure all the perforation checks.
Just a quick note on re-expansion pulmonary edema. A lot of studies show that it's infrequently fatal, and that a lot of patients might respond well just to BiPAP or CPAP first. So it's something you have to be aware of. But if it happens, it seemed unlikely to be fatal. Early studies had a very high mortality from it, but it's such a rare occurrence that when kind of newer data looked at it, it's probably not super dangerous. And kind of as that case you showed, right? They intubated it within 24 hours. They was extubated on CPAP. So.
All right, thank you.